Good evening, everyone. Today we will start a new webinar about total knee arthroplasty. The first one will be on the biomechanics of the knee. This webinar will have a series of webinars. They are classified into 8. Okay, and the first one is about biomechanics of the knee as a start, to know what are the biomechanics before to start the total knee arthroplasty, why it is indicated in the webinar, in the second webinar, and how we manage a pre-operative patient with total knee arthroplasty. Some notes about to do and what you have to perform before the operation. And the third one is about the approaches and different techniques we will discuss later, and how to avoid intraoperative complication if you have doing technical problems may occur or pitfalls and how to overcome it. The fifth one is my favorite, of course, is the controversies in total knee arthroplasty, whether to do or not to do such thing. And there are many controversies, and still it is not documented for example, to replace the patella or not, to use CR and PS. Another thing is that whether there is a surgical alternatives. The surgical alternatives are 3 parts, especially if you don't need to do a total knee arthroplasty. For example, the first one, each one of them has a special webinar. The first one is the unicondylar replacement, and the second is arthroscopic debridement, and the third will be high tibial osteotomy. And if you do this surgical alternatives, or if you have a very high varus or valgus knee, what is called a complex primary total knee arthroplasty, we will discuss in the 7th, and then a post-operative rehabilitation is the 8th. So you are very welcome here, and if you have any questions, you can write it down in the chat, and we will answer these questions. So at first, regarding the biomechanics, why we are studying biomechanics. Actually, we have a larger knowledge of the biomechanics and materials in total knee arthroplasty in order to know whether to put the implants, whether to maintain the right choice of the total knee implants, and whether to know the orientation and rotation of each one. So before that, we will start the morphology. You know that the knee joint is composed of the femur, tibia, and the patella, and there is a soft tissue envelope. The soft tissue envelope, which contains the ligaments, the major ligaments and tendons. We have anteriorly the quadriceps tendon and the patellar tendon, ligamentum patelli, and you have the MCL and LCL, in short, the medial and lateral collateral ligaments. And you have inside the knee joint, both menisci, medial and lateral, and ACL, PCL, the cruciate ligaments. These are the majors, and there are many muscles around it. So I will not discuss this one as a part of the soft tissue, and you will have an applied anatomy in each one during the course of the webinars. So regarding the bony morphology, the distal femur, as you see in this picture, is a unique 3-dimensional shape, which is marked by asymmetry enlargement of the medial and lateral condyles. So each condyles are joined proximally by the femoral trochlear groove, as you see here. This is the patellofemoral groove where the patella is situated and sited. So the groove is characterized with a trough in its lowest point, which is called the sulcus, which is between the medial and lateral projections or the condyles of the femur. This morphological characteristic is very important in both historical and contemporary tests that has been done during the total knee modification, total knee arthroplasty. And there are many measures and many articles about this, how to deal with. We have a circular contour. The circular contour of the posterior condyle which was first documented by Weber, as you see in this picture, and this is the article of Weber brothers. They suggested that they're cutting the femur in the half in a sagittal way and put an ink, and then they put a paper inside it to know the trabeculae orientation of the distal femur and tibia as well. And this perception of the circular geometry, as you see here, that is proposed with Weber, it is a circular with multi-radii, as you see, C1, C2, C3, and C4. These are radii, which are all exactly the same, almost the same, because C4 it's a little bit more longer. So that's why sometimes it looks like a cylindrical or circular. The condyles share a single axis of rotation. On the femoral side, the limb stays in sagittal plane through a range of motion in flexion and extension. And there is no anatomical or kinematic data which support this idea. It is not only flexion and extension, as suggested with Hollister in 1993. So the axis of rotation in the tibia, as you see here in the distal femur, it shares a single axis of rotation, and it is demonstrated by this line, the first line, which is above, in coronal plane. And here you can see that another line below this one, which is this intercylindrical line or cylindrical axis, which does not lie in a single plane. This line, which is the cylindrical one, is the axis of rotation of both condyle in the sagittal plane, okay? So they are not collinear. Actually, the second line in the axial view, if you see the picture below in B, this is the medial, this is the lateral. This first line is the intercondylar line, and this is the second line, which is the intercylindrical line. This line is the axis of rotation. As you can see here, it is intersects the origin of both cruciates. Another thing is to apply here in the mechanics. During total knee arthroplasty, you can see this the green line in the first picture. This is the distal cut of the femur when we are applying the extension gap, while in flexion of the knee, as in sagittal, in the axial view, there will be the red line in the second picture. You can see the flexion gap. So the extension is applied with the distal femur, while in flexion, it is controlled by the posterior condyles. So it should be noted that, again, it should be noted that the foregoing discussion of circular condyles apply the posterior femoral condyles. As you see here, the portion of the distal femur articulates the tibia. It's only from 10 degrees to 120 degrees of knee flexion. The condyles articulate with the tibia at the last 10 degrees of extension, in the last 10 degrees of extension, and have a curvature that are different from the posterior condyles. The sulcus, as you see here, the sulcus in the second picture of the trochlear groove lies lateral to the midplane. Here is another picture showing the sulcus, and this is the midplane of the condyles. In the midplane of the distal femur, it's oriented between the anatomical and mechanical axes, as you see here in the second line, and we will discuss this. The anatomic line of the femur passes up from the femoral shaft to the center of the distal femur. This is called the anatomic axis, the straight line. Okay, and the mechanical axis is started from the center of the femur into this sulcus, into the sulcus. Mechanical line passes through the center of the femur to the center of the distal femur. Relative to these femoral references, so you can see that the sulcus plane is about 2 degrees in valgus with the anatomic axis and plus 4 degrees from the mechanical axis. When we add these together, you will have 6 degrees, which is the difference between anatomic and mechanical axis. Sometimes they are referred as 6 plus minus 2. And normally, you can see that when you have in total knee arthroplasty, when you do an intramedullary nail for the femur to ream the femur up, and you have to do an 6 degree in the valgus. And then there is a question you can answer it at home. In case of coxavara or valga, how can you estimate the mechanical axis of the femur? And what is the degree of mechanical axis indifference between them? Let me repeat this question. Okay. However, in the tibia center below the femur may be depicted repeatedly in anatomical illustration in the surgical manuals. The center of the tibia here, you can see these pictures. Okay. The center of the tibia defines that, if you can see, this is the center of the tibia in picture C. It is defined that the point equidistant from the back to in front. In the cross-sectional or axial view, you can see the tibia, which is serrated now, and you have the dot in the black. Okay, it is exactly from the equidistance from anteroposterior and the mediolateral, which is not confined with that of the femur. You can see the center of the femur on the white dot. And it's usually 4 millimeter posterior and 5 millimeter lateral to that center of the femur. This is a clinical significance. This is a clinical significance in that when you often misled into centering the tibial tray on the femur. So that's why during this, when this occurs, there is an anatomical offset, which is called anatomical offset of the femur and tibia, that centers lead to translation between two prosthetic designs. So the combination of conformity and anatomical translation lead to increase, but it almost decreased the wear rate if you do the anatomical part, when you have the tibial tray as in different center with that of the femur. The knee demonstrating history of anterior knee pain and L patellar arthritis were found to have external rotation of the femur, the tibia on the femur. The external rotation of the tibia on the femur in extended knee, when you are doing extension from 20 to 0, there will be an external rotation about 7 degrees. While in flexion, there will be an internal rotation, as you see in picture B. And this A is a cross section where the femur is transected and the tibia, if you are doing this. So the anatomical significance is that observation and functional perspective, again, is related to the placement of the component in a process of the total knee arthroplasty. This rotational alignment of component is found that the tibial component is externally rotated in 5 degrees in relation to that of the femur. So how about the tibial side? The tibial side, when reference to the mechanical line of the tibia, the articular surface slopes posteriorly 3 degrees down from the lateral and 5 degrees from the medial from the front to the back. So it is not sloped directly. However, contemporary technique of the total knee arthroplasty often replace this slope with an implant placed perpendicular to the mechanical axis, which is called the classical cut of the tibia. So when you have altered the functional morphology, it must be additioned or added in compensatory cut that removed relatively more lateral than medial femur, both distal and posterior, which creates a rectangular space. And this is shown here. You can see that the mechanical and anatomical axis on the axial view of the tibia, sorry. Sorry, back again. If you can see that the translation or the slope of the tibia, this is the tibia proximal tibial slope axis or angle, which is formed anatomically. Another thing is that the patella. The patella is a cartilaginous cap with a surface that is ridge between the patella and the articulating surface. There is a ridge that is divides the patella into medial, smaller, and larger lateral side. The small articular reflection sometimes there is in the medial, as you see in the lower left picture, which is called the odd facet. When we view the relationship of the femur and the patella, which appears, sit on the lateral midpoint, lateral and midpoint. This relationship of the patella on the femur represents both normal and pathologic knee, as in osteoarthritis. And this must be taken into account when positioning these components in the total knee arthroplasty. In the absence of the pathology, as the patella, as you see here in this picture, it lies parallel to the coronal plane of the femur. Is it the coronal plane of the femur? Okay, it is sagittally oriented, but here you have the coronal plane, and you can see that the patella lies in parallel here. In osteoarthritic knee, when there is some osteoarthritis in the patellofemoral joint, there will be an angle, increase of that angle. The appreciation of the abnormal anteversion may lead to surgical correction of the patellar tilt in the arthroplasty, which must be achieved by additional or addressing the rotational femoral component during replacement. Failure to appreciate this will present as abnormal femoral anteversion, which means that lead to malrotation of the patella, as you see in picture B, and sometimes it will have the patellar malattacking and will cause a significant pain in the patella. So these are the formations of the femur, tibia, and the patella. Now, how about the normal alignment? You all know that the alignment of the body when in standing position, you have an anatomic axis of the femur and the mechanical axis. When we are going to the center of rotation of the hip to the center of the distal femur, and we are all know that this angle is between 7 plus minus 2 or 1. And sometimes they suggested that from 5 to 11 degree valgus. But in the tibia, the mechanical axis and anatomical axis are the same. So if any person in a single leg stance, you can see that the whole mechanical axis, the black line, is in 3 degree in valgus from the center of gravity. So the center of gravity is not parallel to that of the mechanical axis in single leg stance. So that's why when we are assessing a patient who is standing, we can add these lines, the 3 degree lines, into the either the medial patellofemoral, the medial MPTA, which is called medial proximal tibial angle, and LDFA, which is the lateral distal femoral angle. The first angle and the last and this one angle, it's about 90 degrees, but you have to minimize the 3 degrees of the standing position. So it will be 87 of both. So this figure must be kept in mind. So the tibial shaft is parallel, as we said, in the joint line, which is not perpendicular exactly to the joint line. So the common describe at 87 degrees of the angle between the joint line and tibial shaft of being 3 degrees in varus, as indicating that this 87 is on the medial side and 3 degree from the perpendicular. But if you have this one, this figure is reduced, for example, 85, we can see that it is 2 degrees only from the anatomical joint line. Regarding the femoral rotation alignment, this is what we called the coronal alignment. Now the distal femur, in rotational alignment, we assess it in the axial view, with posterior aspects of the medial, as you know, and the lateral condyles are defining the coronal plane, the lower green line here, in the neutral position. The position of the lateral epicondyles, if you can see the red line, this is the intercondylar line. And this green line is parallel to the posterior condyles. It forms a 3 degree of external rotation. And that's why you can reference these lines during component, and we will discuss that with the technique during replacement of a primary total knee arthroplasty. Another feature of anatomy is that the distal femur is in relationship to the trochlea that is not parallel with that axis of the rotation of the femur. Regarding the tibial rotational alignment, the best is seen when the entire tibial plateau is exposed, and you can see now when the entire tibial plateau can be seen, the transverse axis from between the midpoint of the medial and lateral tibial plateau in this line. The neutral rotation of the tibial plateau places the tibia tubercle, as you see it, just lateral to the midline. If you are going to have a perpendicular line, like this one, okay. If you have a line like this one, you can see the tibial tubercle is just lateral to the medial midline of the tibia. Okay. So that's why when we are referencing the tibial tray in total knee arthroplasty, it must be in external rotation like that of the anatomic. We don't depend and don't rely on the posterior tibia because the posterior tibia in the medial a little bit larger than that of the lateral tibial plateau, as well as the intermalleoli are not parallel because it is 30 degree from this line, 30 degree external rotation. So the tibial tuberosity alone is not a remark on the tibial tubercle as well as the line of the inter plateau of the tibia. So these are important features of the anatomic speaking. And how about now the biomechanics of total knee arthroplasty? The principal goals of the total knee are to elevate the pain and restore full range of motion. So in order to restore this, we have 4 important things in biomechanics of the knee. These are stability, kinematics, contact stress distribution, and lastly, the fixation. So stability, it depends on, in the modern technique of implant, too many factors. First of all is the size and shape of the implant. The second is location and orientation of the bone cut, the ligament and soft tissue tension that can be assessed during the total knee implantation. And this requires situation in a native medial and lateral stabilizers, namely the PCL, the LCL and MCL. You can see that there are some names like semi-constrained, Semi-constrained total knee, we use the original ligaments, especially the MCL and the LCL and MCL. And these implants are kinematically featured for to replace the function of the ligaments, the same function of the ligaments. So when you have a constrained implants, which is in cases of revision, we stabilize these ligaments by the implant, which is to sacrifice the LCL and or the MCL, both of them or one of them, by the constrained implants. You can see that during the tibial cut and the femoral cut, we have to do the tibial cut in perpendicular to the axis of the tibia. However, in the if the axis of the femur, this is the anatomic axis, you can see a little bit cut in the lateral and more in the medial. It is not perpendicular to the mechanical axis, which is annotated here. This must be in a mechanical axis cut, and then you cut it like this. This is the tool. When you have cut the distal femur, not in the perpendicular to the mechanical axis, you may have not rectangular shape of the knee. So stability now, the thing is that, as you can see here, this is a total knee arthroplasty after cutting the after cutting and implantation, and you can see that the axes both of the femur and tibia in the same mechanical, not anatomical. How about the cruciate ligaments and what we call the femoral rollback phenomena? You know that the tibiofemoral kinematic, the principal motion is flexion and extension, as we described and previously by Weber. Weber described the knee motion. It's not only flexion extension, it's actually a rollback, sliding and axial rotation of the tibiofemoral joint. So the pure rolling alone, the femur condyle roll off the tibia, as you see in the first picture, A, in extension, and during flexion, gradually the femur is rolled back. It is not flexed like a hinge. So this gliding alone, there will be an impingement between the femur and tibial shaft and tibia surface. During early phase of flexion, the femur and tibia predominantly undergo rolling motion, whereas further flexion occur in more than 120 degrees. There will be an accommodation of full range of motion during the knee joint and internal rotation of the tibia. So the tibial, femorotibial roll and slide depend on many factors. The first of all is ACL, the cruciate, and PCL significantly impact this rollback, as the PCL permits this rollback phenomena, and ACL tension, as you see in picture C, you have seen that it is tension in order not to translate the proximal tibia anteriorly. So what will that happen? The ACL and sometimes the PCL are removed during surgery, and these implants may add the kinematic feature of the femoral rollback, and we will discuss it in the next picture. So the implant will restrain and impede the posterior sliding of the tibia on the femur and provide femoral rollback. This is done when a post mechanism of the joint, of the polyethylene. Now this is the femoral rollback, and you can see how is the femur is flexed in more than 120 degrees, and how are the PCL retaining and PCL substituting in the next one. So we start for the stability. It will add more stability for these implants, and then the kinematics. This is what we called in the first picture on the left is the PS, or posterior stabilizing. We remove the posterior cruciate ligament. And on the right is the cruciate returning total knee arthroplasty. It is only the polyethylene that is different, and some of part of the femoral component. You can see here, the femoral component is, there is a gap, and this is post, what is called a post. The post here is interact with that of the femur that permits the rollback phenomena, as we discussed earlier. While here in cruciate returning, or what is called CR, total knee arthroplasty, the native PCL is used. So we don't resect the PCL here. We only use the PCL as the femoral rollback. So most recent total knee implants control knee flexion and extension motion as designed in this geometry. Most of the newer implants have anatomical shape of the femoral condyle, as you see. The radius of the femur anteriorly is larger than the radius of the posterior condyles, other femoral components, in order to keep the range of motion. So the kinematics of the knee flexion is also affected in total knee arthroplasty, whether to spare the PCR, like in CR design of the polyethylene, cruciate returning, and the PCL sacrificing implant, which we resect the PCL. So what are the difference in simple regarding the kinematics? You can see that the cruciate returning natural knee proprioception, because of we save the and we don't resect the PCL, the posterior cruciate, while we don't have a proprioception, but recent studies suggested that there is an equal proprioception in posterior sacrificing polyethylene total knee. So if you don't sacrifice and you maintain the cruciate, you maintain the joint line. You don't need to access more or to resect more. But here in the PS design, we predict the joint line according to the collateral tension. So you can go up or down, or increase or decrease your cuts in order to maintain the collateral tension. Here, we don't need a bone cuts more in the CR knee, because whenever you go larger, you may sacrifice the origin of the PCL. But here, a larger cuts, especially at the notch, in order to sacrifice the sacrifice the PCL. This is a wear rate have shown it is less according to these studies, but a theoretical only theory have a high rate of wear in the PS. So these are only the differences in kinematics. Again, it was the kinematics that we are discussed, and we will continue for the contact stress distribution. You know that the higher stress, the higher risk of loosening. And the stress, what we are calling as, is at the level of the bone implant interface. The aim is to reduce the load at this interface, the bone implant. Otherwise, stress shielding and load to failure may occur. So the primary mechanism of wear, the primary mechanism of wear and loosening is that when we are fixing the implant with a low contact area, which results in large compressive force through a comparative smaller size of the polyethylene. So fixation with a low contact area of stress will maybe cause a higher compressive load in relation to the liner or the polyethylene. So uniformly stress will maximize this contact area. Generally speaking, the tibia have, if you have it in, for this example, a tibial implant, which is less than 6 millimeter, is not used because it is too flexible and may cause a mechanical deformation because of high stress on this low area. And thicker tibial component can provide an increased distribution of the contact stress between the bone and the implant. So that's why if you increase this, the lever arm will be shifted away the shear stress. and increase risk of loosening, of course. So what to do? يعني إذا إحنا خلينا tibial implant very short, it may have failure. And if we are going to be thick, there will be a problem. So the primary mechanism of failure, of loosening, there are two chief mechanisms, which is first of all, the contact stress and the micromotion in the interface. So you have to decrease whenever to use a low one below 6, which is not admitted in the manufacturer. So you have to put the tibial tray, which is larger than 6 millimeters, but not so much large. So this depends on the cement in the tibial tray. This will increase the conformity and uniformity of the stress distribution at the implant level of the implant bone interface, which is more distributed than the cementless, which is done by the guy Miguel in 1986. So the contact distribution, as you see here, it depends on a precise and precision of the bone cut, the implant size, alignment of the component, the joint line, restoration, and proper ligament tension. In addition to metal tibial tray beneath, the polyethylene provides a stiffer foundation of the polyethylene. Therefore, it results in more uniformly distribution of the stress at this interface, which is called the bone prosthesis interface. The metal tray reduces the overall compressive stress in the underlying cancellous bone. And this has been demonstrated as the tibial cortex should be included in the fixation with a maximum coverage at the resection surface, which is optimal for stress distribution. In addition to aforementioned factors, you can see that these factors are very important. The precise cut, implant size, alignment of the component, joint line restoration, and the proper alignment of tension. And additionally, if the anatomic alignment is not obtained, last one, the joint reactive force the joint reactive force may be increased and may have shifted and subsequently in increased stress at the bone prosthesis interface or bone implant interface. Finally, the fixation, as total knee prosthesis can be implanted using either cemented or cementless technique that use a screw or pegs. And considerable controversy exists over the best method, but still clear that precise surgical technique in implantation requires regardless of the type of fixation. Well, that is about the biomechanics of the total knee, and thank you for listening. If you have any questions, I'm glad to hear. Dr. Ahmed, he said that flexion in the posterior part. Yes, flexion actually in the posterior part more that is controlled by the femur, the posterior condyle of the femur. If you want to share an idea or you can talk freely, just choose raising hand and ask, please. Thank you. Thank you, Dr. Hassan. Okay, I think we have a question. Oh, thank you.
Hello.
Yes, I can hear you well.
العفو دكتور سنان بالاكسترنال شيء دقري ايش قد بالاكسترنال يصير اكسترنال روتيشن بالتيبي على الفيمر
بالاكسترنال روتيشن usually in extension of the knee it is 5 degrees plus minus 1. 5 degrees yes.
وانترنال روتيشن بالفليكشن
The same.
سيم يعني مو كانت 7 ب5.
It is minimum. Some of the surgeon أو biomechanical studies in MRI, but dynamic MRI, they suggested that during flexion up to 120, it is the same 5 degrees. It adds another 2 degrees of internal rotation during higher degrees of flexion of the knee. So that's why in regards of the total knee arthroplasty, when you put the tibial tray in external rotation, it must not exceed that of the tibial tuberosity or tubercle. Otherwise, you may have an increase in internal rotation during knee flexion. You see what I'm saying?
اوكي عشت ايدك.
Okay. Thank you for joining. Yes.
دكتور سنان برايك الكونسترين افضل لو كميكانيكال لو اللي بيسوي بريزيرف للاي سي ال جوينت والبي سي ال؟
So ACL actually, there are many theories that are suggesting both cruciates are not used, that are used, sorry, for the retaining, and they have still failures, especially in the ACL, because of that the tibial tray and the femoral component cannot be aligned. Regarding the CR and the PS total knee arthroplasty, there are many differences, and both of them till recently have suggested more than 25 years of retrospective studies shows both of them have the same wear rate. هم دا يشوفون يعني المشكلة بالwear rate and mechanical instability. Both of them have the same mechanical stability. Yes. So رح نحكيها هاي بالمحاضرة اللي هي Controversies of the total knee. And still now, regarding the part of the of suggesting total knee arthroplasty, whether to use this or that, they are all almost the same. بالنسبة الموضوع مال إنه إحنا biomechanically they are not so different, but in the case of the post and cam during the PS, it replaces the PCL. However, you can see that more cuts are used in the PS in order to maintain the severe varus or valgus deformities.
الو
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 هلا استاذ.
هلا دكتور سنان، شلونك؟
حبيبي استاذ، الله يخليك ويسلمك.
هلا بس اريد اعلق كصوت.
Yes sir, of course.
ما ادري دا يوصل صوتي؟ دا تسمعه؟
دا سمعون اخوان الدكتور محمود الشاب يعني.
اذا نسمع ممتاز. اشكرك دكتور محمود، والسلام عليكم.
هلا وهلا استاذ.
اسمع واضح.
اوكي. اني حقيقه اشكر السنان، يعني هاي المواضيع بالتوتال ني موضوع كلش واسع مثل حال الهب، واحنا بالنسبه للسيرجن يعني تو ستارت وذ لازم نلم بكل المواضيع. هي مو مساله دريجه نخلي امبلانت ني بالركبه، لا، انت ايش قد ما تفتهم البايو ميكانكس والبالانس بالنسبه للسوفت تيشو and how you cut the bone راح يصير عندنا optimum results. الكيسات اللي تصير بيها instability يعني اللي اذا نشوفها وطبعا يجينا painful knee because of the lacking a simple principle when you are cutting the bone. Yes. مثلا لما يقول 90 degree الفيمورال cut must be 90 degree on mechanical axis. ايش راح يصير؟ راح يصير difference between the lateral and medial. هذا يعني احنا لو نرجع للبلان، لو نسوي mechanical line and tibia, mechanical axis of the tibia and mechanical axis of the femur، راح يطلع عندك we get an idea about how much varus and the varus, whether in the femur or in the tibia, and how much it's valgus, whether in the femur or in the tibia. ولهذا you may cut varus cutting. varus يعني medially راح يصير هواية. varus cutting in the femur and valgus cutting
in
the tibia.
In the tibia.
In the tibia. يعني the lateral part will be more than the medial part. This is depend on your plan. Maybe the case is varus in the femur, maybe valgus in the tibia.
Yes.
So tibia and the femur has a special axis, mechanical axis perpendicular to the line which is passing from the condyle, and mechanical axis of the tibia, which is with the proximal tibia.
Yes.
So whenever you know the mechanical axis, both of them you can cut. This varus cutting or valgus cutting. This is first regarding the cutting. بالنسبة للsoft tissue balance، أنا ما أدري إذا صارت محاضرات أخرى، لازم إحنا بالنسبة كجراحين نعرف medial balancing in extension، medial balancing in flexion، شنو الستراكشرز. لهذا لما نسوي balance in extension.
ألو أستاذ تسمعني؟ ألو.
اوكي سنان تسمعني؟
اي هسه دا اسمعك استاذ.
Yes.
regarding soft tissue balance وصلنا استاذ.
Yes, soft tissue balance. عندنا medially MCL.
Yes.
وعندنا laterally LCL والpopliteus tendon.
Yes.
MCL اللي هي medial collateral ligament. It's important from step by step. We're going from the deep part, then we're going to the C membranes and the posterior capsule, then we go to the superficial, and this is depend on every extension and the tightness. You get first two step, inflection second step. بالنسبة للفالجس كمان structure LCL والpopliteus.
Yes.
Cutting and soft tissue balance. If you get your idea يعني and خلينا نقول يعني الاناتومي مالته إذا عرفناها you are 80% optimum knee surgeon if you know the soft tissue and bone cutting. النقطة الأخيرة بس أريد أعلق بالنسبة للسي ار والبي اس. السي ار always when you try to use it, please use it for the moderate cases, mild or moderate.
Yes.
Where the soft tissue PCL has no rule in the deformity.
Of course.
لأنه PCL if there is rule in the deformity so you must go to the PS. Secondly, in rheumatoid arthritis old ages دائما احنا نشوف PCL is fibrosed or rheumatoid lax.
Intersubstance tear. Yes sir. Intersubstance tear يصير بها.
بالضبط. You must plan for going to PS. أنا أقول أكو جمعية الرفق بالحيوان، هذا نسميه جمعية الرفق posterior cruciate ligament. نقدر هذا لكن لأنه تدري هذا it is a natural tissue ligament soft tissue يعني صعبة علينا نسوي الكاتنج. لكن السي ار الليميتيشن مالتها هي انه نقدر بالمودريت، لانه الكيسات اللي انا دا احكي عن الكيسات اللي بالعراق.
Yes.
اخوان ترى patient present at the last stage an advanced stage. So يعني مجالات اللي نستخدم بها السي ار مجالات قليله. اشتغلنا احنا تقريبا 150 200 واحد. النقطه اللي بالسي ار الفليكشن لحد 90 ورا ال 90 شويه عندنا ليميتيشن، ما راح ينطينا فليكس تايب حتى نروح يعني 120 140. ليش؟ لان راح يصير تنشن على البي اس maybe and this is causing يعني يصير rupture and then we got loosening.
Yes.
يصير rolling mechanism fail عندنا. فالسي ار هي سهله لان النوتش ما تكتب، وثاني you keep the bone ماكو قطع يعني cutting of the bone
Yes.
and one step you skip it, but it has its limitation.
Yes.
لذات والنقطة اللي لما تكتب تيبيا بالسي ار يعني لازم تسوي اوستيوتومي شوية حول بي اس حتى لما تقص المنشار مالتك يروح على البي اس، لأنه مرات لما تقصه ما تسوي بروتكشن هوب قصك البي اس وانت البلان مالك سي ار فقلبت الامبلانت صارت البي اس. فلهذا السي ار شويه هذا يعني
limited use, yes.
to be limited indication for our patient العراقيين. ليش برا يستخدموه هوايه اوروبا؟ لانه المراه اول ما يعني المريض اول ما تحس بالالم بتراجع الطبيب، اكو انشورنس. ولهذا تشوف ليش احنا عندنا هسه يوني ما عندنا، ماكو نادر من الكيسات يجينا انتيروميديال ارثرايتس وكل السوفت تيشو اوكي، لانه هذه لما يقول له اليوني ما تقبل، يعني الدكتور انا ايش بيه هناك بس يجي انتيروميديال ارثرايتس
يسوي
لي يوني كوندايلر.
يس اوف كورس.
لهذا احنا شويه عندنا الليميتيشن. والنقطه الاخرى انه احنا بالنسبه لنا لانه بالعقد مال وزاره الصحه كلها بي اس، لهذا انا دا اوجهكم على هذا. سي ار ما عندنا فيري ليميتد، بس سترايكر اعتقد عنده بالبرايفت، بس الزمر هسه السي ار ما عندنا. انا ممنون اتاحتي على الفرصه على الناس وعاشت ايدك على
خلينك استاذ لانه احنا عندنا بعد عندنا هم كم سؤال.
دكتور حاضر.
هنا another question. The femoral cut depends on mechanical or anatomical axis. Actually, it depends almost always in the mechanical, not anatomical axis. And you see that I go back in the lecture as you see this picture. When you have done the femoral cut, the distal femoral cut is perpendicular to the anatomic axis of the femur. What would happen to the gap, the distance of the knee? And you can see that the knee is almost in valgus and the femur in varus, and it is not in perpendicular not parallel to the joint line. الهدف مالتنا احنا من نريد نسوي total knee arthroplasty you restore the joint line level and the orientation. ما ادري واضح الصوت اخوان؟ الو واضح الصوت بالنسبه لنا؟ So we have to know that the aim of the arthroplasty during total knee arthroplasty, you have to put the cut on the medial, on the perpendicular, on the mechanical axis of the femur and the tibia as well. If you do anatomical axis perpendicularity, you will have صحيح rectangular design, but rectangular gap, but you have it is not parallel to that of the joint line. استاذ محمود الشهابي اذا عندك تعليق اكون ممنون استاذ. Hello. Okay, another question is that Dr. Hussein Zofi, will you Blumenstadt line use as a landmark or not in biomechanics? It is landmark of the X-ray, but it is not in the biomechanics of the knee joint. We are seeing that the every line in the knee that we are confined it with the total knee replacement in knowing the biomechanics. Actually, we know that in each line there is orientation or movement around an axis or around the line or the cut. So Blumenstadt will not use it. Any more questions, please?
الو دكتور سنان.
اي استاذ وياك.
تسمعني؟
وياك استاذ. اوكي.
بس الصوره اللي مطلعها انت هاي بدنا نشوفها. هذه هذا اكستنشن جاب.
يس.
بس حتى نميز الاكستنشن جاب بين distal femur and proximal tibia.
يس.
لو تلاحظ ان الكاتنج مالك راح يصير فارس كاتنج لانه الفيمر فالجس.
يعني فيمر
فانت راح تاخذ ميديالي اكثر. ميديالي انت كاتنج مالك اكثر.
بالضبط استاذ.
يعني هذا يو ار كاتنج فارس كاتنج تسوي.
فارس كات.
لما تيجي على التيبيا التيبيا
فالجس.
لاترالي اكثر، يعني انت تسوي فالجس كاتنج.
صحيح.
ليش؟ لانه انت الايم مالك تصير متوازي الاضلاع، الاكستنشن جاب يصير متوازي الاضلاع. بعد هذا الكاتنج قسم من الاطباء اخواني ايش يسوون لما يشوف انه بعده ايش راح يسوي؟ يروح يقص اكثر، يعني يصير يعني كاربنتر. لا، انت بعد هذا القصه مالتك according to the plan اذا اكو المتوازي الاضلاع بعده unbalanced اذا بالسوفت تشو. هسه تيجي دورك اللي حكيناها
اللي هو
medially maybe بMCL يراد لك شويه ريليس حتى تروح المتوازي الاضلاع. laterally اذا عندك البوبليتيوس عندك تستار كبسول، بعدين LCL. بعد ما تقطع انت بالبلان هذا قاطع فرانس يعني مضبوط according to the plan. If there is still unbalanced, so the cause is in the soft tissue. Go to the soft tissue. لانه اذا اخذت بون زياده ولا هذا لا تعدل، لا تسوي متوازي الاضلاع by bone only, because at the end when you put the implant لما تقطع الفليكشن جاب will create a problem. Medially may be loose, laterally may be tight.
Yes.
And this will be create a problem for you. ولهذا انت هسه مخليني الاكستنشن جاب. الفليكشن جاب لما تسوي فليكشن هي between الكوندايل and proximal tibia. الكوندايل همين الكوندايل الهمين medially تروح اكثر من اللاترالي اللي بها روتيشن. لما نقول روتيشن external rotation 3 degree او 5 degree بمعنى medially you are cutting more
than the lateral
9 to 11. Yes, medial and هاي هي انت extension gap قصيت flexion gap. Now you go for soft tissue. And how you cut it in extension first, second degree, in flexion go to superficial MCR. And بالهذا اليوتيبال bind in extension هذول الستابلايزر، بالفليكشن عندك popliteus LCR. شكرا عند دكتور سنة. وياك.
Thank you. Okay, any more questions? Thank you, sir, Dr. Mahmoud, about this interference. It's very, very important. And these notes will be later in the techniques after the webinar 3, I think we said it. حتكون the webinar 3 about the techniques of joint arthroplasty, of the total knee arthroplasty. Thank you very much for your attendance and have a nice day. موعد المحاضرات اكو فد جروب او فيس اي والله دكتور شوف بالنسبه للمواعيد انا دا اكتبها بالجروبات كلها، فاذا اي واحد من اللي يسمعونا من البورد and the seniors also, if you have a group, a special group for you, اتمنى انه تاخذ هذا كوبي بيست الى بقيه الجروبات. عاده دكتور محمد انا دا اسوي المحاضرات الساعه 9 كل يوم سبت، واذا تحبون ان شاء الله راح انطيكم لينك همينه بالجروبات اللي انا مضيوف بيها. ما ادري اذا يعني عندكم انتم جروبات اخرى، راح يكون عندنا بعد ما اسويها ابلود in the YouTube، وهذا رقمي اذا تحبوه for everyone to add me in your groups. I'm very thankful for your help, Dr. Mahmoud Shahab, and thankful for everyone who is attending here. Thank you very much and have a nice day.